what is good instructional design for also online learning. So we need to make sure that when creating and designing content, we also put instructional design methodologies that correspond to the pedagogical experience into the creation process. So I personally think that also the funding of content is an important aspect that we will explore. And we're currently discussing this in the context of the next annual call for Erasmus, which, however, will be for 2022. So it is still to be confirmed.
Thank you. We still have some time. And there's another interesting question from Vera Meister. She's asking, what are the main approaches in perceiving multilinguality in educational content? So what is your take on multi?
Yes, from our perspective, anything that is put forward by the European Union has to be by default multilingual. And this is, of course, a different type of challenge than when it happens on a member state level. So we, of course, are very much aware that this is something that we at the Commission level perhaps pay very, very special attention to. But well, I think that we have a policy, and this is what I can say to this question. We have a policy where essentially any type of specific platforms that we run have to be available in all the different languages. And to operate the functions is very easy. That's not difficult. What is much more difficult is when the content itself has to be translated, and then, of course, quality assured. So I cannot comment a lot more than just acknowledging that this is a very, very significant problem, and this is why I have mentioned it in the context of the platform, that this is one of the questions that we are asking ourselves, to what extent we can, let's say, reflect the need that we identify for multilingualism, which is basically for anything that we do to respect the cultural diversity of the member states, and of course it is rooted in the languages ultimately. So I'm afraid that for the time being, I can say only that.
One last question before we move on, and that goes from Matthias Enderle on the question he's asking, is there research existing on the importance of face-to-face learning for children between 4 and 5 years and 18 years compared to digital learning? So are there research results you know of which reflect how important is face-to-face learning versus digital learning?
This is an excellent question. Thank you very much, Matthias, for it. I would like to see a longitudinal study, say 10 years, comparing both. Unfortunately, I don't think there is anything like that, just because no one probably thought that would be a real sort of research question. But now for sure it is one. No, I'm not aware of anything that is EU encompassing. I'm aware of some studies that look at the relative impact primarily of blended and just pure online, but not compared to a counterfactual like let's say physical. However, what I can already say here is that this question of the blended learning, in particular for the children that you have put forward there, is something that we have been very, very busy with from the point of view of the adaptation that at least our primary and secondary education and training systems need to prepare for, in case there would be the situation that we have experienced again. And we have looked at a lot of practices that tell something about how a school can prepare for this. this is not linked to a recommendation to do it, so just to be clear, but it's more about the planning that needs to go there, the engagement of also of the parents, the type of pedagogical methods that can be used if it happens. And in fact, we will be proposing as part of the action plan. I have not mentioned it because it was not intended to list all actions that we work on. But in fact, the very first action that we are going to complete, and I hope it will be just in a few weeks from now, is a proposal for a council recommendation on blended learning in primary and secondary. So in this proposal, we are essentially providing some tools and guidance on what can be used to make the process of blended learning more effective, but it does not yet reply to your question, of course, whether this is ultimately more effective and how does it compare to the pure face-to-face. Thank you.
So, Dr. Dimitrov, thank you very much again for your time today and for all the information you provided. I think we'll have our next speaker waiting. Our next keynote speaker, well, actually has been on the forefront of fighting this pandemic on a global level. As the head of learning and capacity development at the World Health Organization's Health Emergency Program, Dr. Gaya Gamhewage was responsible for making information on COVID-19 rapidly available to health workers around the globe. OpenWHO, WHO's online learning platform developed together with HPI, saw exploding numbers and had to scale quickly to serve the need for information. This also meant translating the courses offered in more than 50 languages. Dr. Gamhewage will share her insights on how to tackle the pandemic with online learning. So please welcome Dr. Gaya Gamhewage.
Thank you so much, Christian, and what a pleasure it is to be here. And any event open in collaboration with HPI is always a very sweet moment for us, because when we started our collaboration, we didn't know how impactful this would be. If Christian, if you could just confirm with me exactly how much time we have.
It is scheduled until 4 p.m.
Thank you so much. If I may share my screen. Thank you. So I really look forward to, answering questions and going into the discussion. But to frame that, I wanted to take a step back and look at this topic of how, not just us, but how anybody can fight a pandemic with online learning. This idea would have seemed quite ludicrous, in the past, because you fight pandemics with contact tracing and outbreak investigation and clinical management and community engagement. But really, the concept that learning is central to fighting any pandemic, but also epidemic or health emergency, hasn't always been obvious to everybody. I'd like to take you through some thoughts that I have related to this. So if we take a step back, we have to really understand why we are having an increased risk for amplification of epidemics and pandemics that require us to learn in a very different way. This is a picture taken, if you like, a visualization in 2012. This is nearly a decade ago. And imagine this even more, of global travel in one day, global air travel in one day. You can see that people and also pathogens whom people are carrying can move from one part of the world very quickly to another because of the way we live our lives, global economy, global trade, global travel. Now, this means we are actually at increased risk because of the way we live. We also have urbanization. More than half of humanity live in crowded, urban settings that are really hotbeds for epidemics and pandemics. And by mid-century, we're going to have 68% of human beings living in cities and towns. There's poor infrastructure. About, I think, 1/3 of people who will live in cities will be living in substandard conditions, in slums and so on. And you can see most of COVID has spread really easily in cities because we are crowded, because we're in close proximity, and because we depend on each other for daily needs. There's poverty, lack of access to education, health services, and employment increase your risk of getting pandemic diseases and increase your risk from dying or suffering or losing your livelihood because of that. There are many risks at the human-animal barrier. As we do massive deforestation, as we do the way we do massive livestock development, agriculture, the way we misuse antibiotics. About 70% of antibiotics are used for animals, not for us. And we are increasing the risk of animal diseases in animals, jumping species and coming to us. Of course, we are not surveillance, early warning, poor response capacity, but also technological advances. People can manufacture pathogens quite easily now, and these can be weaponized or they can accidentally be released. And of course, people's beliefs, traditions, and practices. You can see there is a significant amount of people who don't believe in vaccines. So even if the global health response to the COVID is to vaccinate people, it's one of the responses, you may still have people who say, no, I don't want to be vaccinated. So all of this is increasing the potential of pandemics. And in fact, some experts say we are in a pandemic era. And really what a pandemic is a new disease, usually from animals, which jump species to us. So we don't have prior immunity. And this spreads all across our planet. Pan means everywhere, and demi means the earth. So that's all this is. Now, what has this got to do with learning, I hear you ask? Well, in an outbreak, a disease outbreak that can start from a localized outbreak, can grow to an epidemic, and can become a pandemic, there are many moments which are very critical, and we have to learn and teach others things in order to act in each of these stages. The first is really the anticipation and preparedness stage, before there is an emergence of a new disease. Soon as something comes up, we need people in the system, in the community, need new knowledge and skills for early detection and reporting. Once there is a localized outbreak, our job is to contain it. That requires different knowledge, different skills. Then, of course, we have epidemic amplification. And with that map I showed you, this can happen very quickly. We need to do mitigation to reduce avoidable death, avoidable disease, and avoidable loss to livelihoods, economies, cultures, and societies. So all of this, so we're not learning the same thing across this process. We need very specific knowledge and skills at different stages. And you can see you have to be very quick. So we can't follow the traditional process, trajectory, timeline of how knowledge gets codified, gets transformed into learning, and then it's made available to people and people acquire it and use it. There is an incredibly different thinking, process, and timeline that is required to learn in emergencies if we are to use learning as a tool to fight health emergencies. So, this is what happens, the orange curve, if we don't really intervene. More and more people will get sick, more and more people will die. And then eventually, if everybody dies, the epidemic or the outbreak will die off. And this dotted line is the healthcare system capacity. So one of the things you would have seen in the COVID-19 was how to flatten this curve, how to really not have this quick peak, but to control the transmission so that the healthcare system didn't get overwhelmed and that the system could save lives. A lot of learning had to happen for individuals, for communities, for healthcare workers, for decision makers, for people who manage hospital waste, people who drive ambulances, in order to go from this to this. So this is again about the different things we have to learn and the speed at which we learn. For those of you who may not know the World Health Organization so well, we are the world's health organization. We are made up of all the countries in the world. The governments make us up. And in terms of infectious outbreaks, epidemics and pandemics, WHO has the global lead to respond. And in countries, we work with the ministries of health and others to manage the response. If it is a humanitarian conflict or a natural disaster, the whole UN system, there is a mechanism to lead it called the Interagency Standing Committee, and WHO will lead the health response in that. And for chemical disasters, nuclear disasters, specialized mechanisms. So you see, in my job as head of learning and capacity development and for OpenWHO, we can't just focus on infectious disease outbreaks, but we have to offer learnings for any of this, because today we are at risk of all hazards: natural hazards, armed conflict, infectious outbreaks, chemical disasters, radionuclear disasters, and also food emergencies. So this speaks to the scope of areas which we have to cover. But we have to remember, this doesn't happen in a sterile environment where I have knowledge, we have the platform, and we give it to people and people accept it. We live in a really a world full of inequity. Life expectancy has increased 3 years. Actually, this is wrong. 11 years in high-income countries, but only 3 years in low and middle-income countries. 71% of deaths are due to what we call non-communicable diseases. These are diseases such as cardiovascular disease, chronic obstructive respiratory diseases, diabetes, and cancer. So while we have this COVID and pandemic, we still have to make sure people are learning about how to manage the diseases that really kill most people. There is an 18 million health worker shortage. What does that mean? It means people who are not trained and qualified are having to deliver health. So we have to provide educational opportunities for them. You can see in the next two, less than 10 doctors per 10,000 population, less than 40 nurses. These are the minimum standard. But half the countries in the world don't have enough doctors and nurses. And so people who are not qualified to do that are having to provide those services. Essential healthcare in 2017, only 1/3 was provided for only 1/3 of the populations. At least 13% of the global population, that is 1 billion people, will spend at least 10% of their household income on healthcare. There's a lot of learning around that. And let me just jump to this one. 40% of households lack access to basic hand washing facilities. So when we provide training and say, wash your hands, people can't implement it. So there is the no-do gap that we have to address when we think of learning. And even before the pandemic, 95% of countries were not on target to meet the Sustainable Development Goal 3 on health. So we are in a really challenging situation, and we're not like universities or education institutes. We are the world's public health institute. So what we need to do is to promote learning, support learning, keeping in mind the reality of the world, that the world is very unequal. Even when we do online learning, that many, and in fact, in some countries, most people don't have access to broadband internet. Now, COVID has made things worse, as you will know. Much of the gains that we made over the last 10, 20 years has been reversed. The pandemic has interrupted childhood immunization in about 70 countries. So we are going to have to go back and do learning and programs on restoring these immunization practices. We expect illnesses such as malaria will rise. We think there'll be 100% increase in malaria deaths. So we may be having to redo learning on and malaria has been around for thousands of years, these diseases, on how to control them, but in today's context. So really, this is going to be a very challenging time as we go ahead. So the key ideas are these. Learning for protecting health is an important component for protecting people from health emergencies, and that they live in good health. So you cannot have health for all if we don't have learning for health for all. Everyone needs to learn, and to learn across their lifetimes. Lifelong learning for health is here to stay. And one of our key principles is to make sure that everybody who needs it, health professionals, volunteers, individuals, families, can access appropriate, timely learning opportunities across their lifetime. And it is very important, because of the kind of organization we are and the inequity in the world, that barriers to accessing learning must be not ignored, but they must be proactively dismantled. We cannot wait for someone else to remove these barriers. So why did WHO, a health organization, and I'm a medical doctor, why on earth are we embarking on online learning? So my story is simple. It's a personal story and the story of my team and my organization. In West Africa, 2014 to 2016, there was an Ebola attack that really challenged the world, not just the people in that region. The best experts, the best teams were sent from the United States of America, from the United Kingdom, from France, from many countries and other countries in Africa, from Uganda, Congo and others. And it took everybody's effort, but it took a long time to bring under control. And I was appointed as the international training coordinator for this, and a large amount of training happened. And this is what training looked like. We had experts go in and train people on infection prevention control, caring of Ebola patients. And we had to do a lot of work at community level. I was actually deployed to Nigeria, and this picture is from Nigeria. This is a group of women celebrating the end of Ebola in that area. So this is what training looked like. And I was told that I had 6 weeks to train 108,000 people for this response. And I began to understand the scale and the scope of this. Of course, we worked with many agencies and we managed to do this, but really what were we doing? We were taking a memory stick, putting all our resources on it and sending it to the field, and nobody had time to open this. And it really was very, very hard. But we did start an online training program at that time called eProtect. And this was a compulsory course on how to protect yourself, work safely in the response and the strategic response pillars for Ebola. So anybody who was deployed under our flag had to complete this course. And this was really the beginning of, in this area, the work. And immediately afterwards, I realized this is not going to work. So we looked for a suitable partner to collaborate with, and HPI and the great colleagues there, I see Professor Meinl is there as well, stood up and we formed a partnership, a collaboration. They're a service provider, but they've been more than a service provider. They've been a true partner. And we launched this platform called OpenWHO. And the name was very poignant for me. We wanted it to be truly open. And we started, and I know that there are many colleagues online, and one I have to mention is Heini Utunen, who really started working with me, and a colleague called Oliver Stuke and Ursula Drau. And together this small team started working on this platform, and we took little epidemic and pandemic prone diseases. We always thought we need a massive open platform that could scale up into millions if there was a pandemic, right? And Heini has taken that work and she leads it completely now. So any success that is attributed to WHO, really it goes to her. I was very lucky to be leading this team and to grow this concept. And what we really wanted to do is address the situation we saw in Ebola, but also we remembered that we had been through a previous pandemic and we wanted to be pandemic ready. So in early January 2019, when WHO was notified that there was a novel virus, a coronavirus in China, we sort of jumped in, no regrets, and started preparing for this. And we were on good grounds because there was another coronavirus, MERS, that we had done some courses on. We worked with the expert. And in fact, even before a public health event of international concern was was announced, we were able to produce a basic course on the knowledge depending on what we knew. Now, I said before, new viruses mean new knowledge, how they are caused, how they're transmitted, how they can be managed. So knowledge will evolve over time, and we need to update anything we put up all the time. So this was our journey, and thanks to the preparatory work and done with HPI on OpenWHO, we were pandemic ready. We were off the starting blocks very quickly. It is now our flagship interactive web-based knowledge transfer platform. We offer mainly online courses, which are asynchronous, but we have started doing synchronous courses as well for smaller groups, virtual interactive classes, virtual labs, and we've recently introduced online drills through a simulation exercise software as well. Now, from 2017, we've really had a great growth, but it was very important that it is free of charge to the user. It's like free health. Somebody has to pay for it, but we don't want the user to be blocked by having to pay to access it. Mostly self-paced, because we know adults need flexibility and people in emergencies really need to find their own time to get the knowledge they need. We made sure right from the beginning, from design, it's accessible in low bandwidth settings and is accessible offline with the app and available in local and national languages. When we started this journey, we could not have imagined how far we would come. You can see when we started in 2017, we were so excited with the first 1,000 enrollments, then the 10,000, 19,000 seemed like, oh, that was a great year. But then in 2018, it really went up, 443% to nearly 100,000. By 2019, you can see, and by 2020, more than nearly 2,500%. And today, I think we have more than 5.3 million course enrollments. This was done by Haney with only one full-time staff, with us helping, but working with service providers. It's an incredible enterprise to show if you get the philosophy, the value, the system, and the orientation right, great things can be done. We were obviously catering to the demand. We obviously understood what people wanted to learn about. So here is our, if you like, our hall of pride. And I think the HPI should actually feel very proud when they look at this. 5.3 million total course enrollments, 34 COVID topics, 65 other health topics. And that's why I talked to you about the big issue about public health. 2.8 million certificates. That means people have finished the courses and proven that they have gained some knowledge. 54 languages. This is really a source of pride, because what does this say? It says that people at the front line, communities, people who put in their lives at risk can get life-saving knowledge. 9.6 million words translated. Fast, I must say, crowdsourced, not all paid for, volunteers, people just coming to us because they believe the philosophy and the value system of this was right. 1,781 videos. Haney tells me we are up there with the top users of Vimeo, and 30,000 plus hours of videos watched. You can see top countries. India, United States is at the top. You can see it's wide ranging. It's from around the world. We have every country coming on the platform, but these are the top users, the top courses, right? Top languages. So it's really, really an interesting thing. We have many channels. And most recently, we launched the channel to service countries. So countries can quickly go up there, find all the courses that are relevant for languages, their own languages. And you can see there are many. I won't go through it. And they're not all COVID, you know. We have universal health. Our Ready for Response is a very good course that will very soon, we're piloting it, very soon it will be made compulsory for anyone being deployed in health emergency. Neglected tropical diseases, Get Social was one of the earlier channels about risk communication, community engagement. Go Data is very specific about how to do epidemiological investigation, outbreak investigation, how to turn that into a response. So very specific to very broad. So we've worked with more than 70 technical teams across WHO. Now, this is another asset that we have. The technical expertise is within our organization, but it's dispersed. But we actually can convene them and bring them together. So we're not waiting for technical, content experts to come and work on courses with us. Also, as I said, it's targeted to what people need. This is the COVID response. The pillars at the bottom are the pillars of global response that we are advocating every country takes. And Heine has been very clever. She works very closely. She actually develops courses that actually support every pillar of response. So if we're asking people to, do something for points of entry, she's already got the course there. If we're doing maintaining essential health services, she's got all of these courses there, right? So this is really about aligning the strategy for response with learning. Learning cannot be separate from response. Learning has to be for achieving health objectives. So what are the key ingredients for impact? It has to be free. This is non-negotiable. This has to be free. If rich learners come to us and they want to donate money, they can donate money to the foundation and we can channel that. That's not a problem. But we have to remove cost barriers. This is very, very important. It's very fundamental. And that's why I'm really happy even this session is being broadcast on YouTube and people can watch it for free. You have to have, I know about AI, I know about gaming, I know about all of these learning tools using, we're in the fourth industrial revolution, but we cannot exclude people. We have to have low bandwidth solutions for this. We have to have offline solutions. Just one statistic, only 22% of women in Africa have access to internet. That compares with about 32% of men, right? Women are at the front line, they're in the community, they give care, they identify disease, they are community health workers, and they are 70% of the health workforce, usually in the lowest paid and low status professions like nursing or midwifery. Right? So we cannot, just because there are great solutions out there, we cannot use that. What we need to do is try to find a way to get those solutions to people who are challenged with digital access. Languages is very important, particularly under pressure. If you look at psychology, neuroscience, risk perception, people are under stress and they learn best, comprehend best when they are working in their own, not just official language, but their dialect, their local language, their mother tongue. So this has become a crusade for us. We really, really want to do this. Choice of formats. So we may have great videos, but in certain cultures and because of low bandwidth, people can't access videos. We have to offer small, short audio files. We have to find other ways of getting this across. We have to respect adult learning science and integrate that in all learning. And of course, real time, really fast production. If we are slow, the pandemic and the needs have changed. And we have to do it at massive scale. So this is what I've learned, so that we allow people to work in the response for a coordinated response, also including individuals' health literacy and agency, ability to act to protect themselves and others, providing tools and resources for applying the knowledge, not just getting the knowledge, and creating this appetite for a learning ecosystem where today I'm the teacher, tomorrow I'm learning, the day after I'm helping someone else learn. This tradition of I am the professor and you're the student, I believe this is dead. And I'm very happy, hooray to that, because we have a lot to learn. The pandemic has shown us knowledge is generated not just in universities, but in the field, in homes, through practitioners. So we have to remove the hierarchy and the unidirectional flow of knowledge. And we should find ways, and technology should help us find ways to harness that, to codify that, to share that. So these are, of course, while we're doing this, Heini has led, really, she's incredible. She has led, I think, more than 10 peer-reviewed articles, many of them related to OpenWHO, some of them together with HPI. I'll leave this for you. I clicked the wrong thing, excuse me. Let me just finish off. Very sorry about that. And I'll also I'll leave this slide as part of the pack. And this slide, if you get this presentation, if you click directly, you will go to the courses in WHO languages and different things. So this is really what I wanted to share as a conversation starter. And happy to answer any questions and join the discussion. Thank you again so much for inviting me to this. This is such a pleasure, because it's not often that we start on a journey where we don't know where we are going, but there's just so much that we've been able to contribute together. So thank you, all colleagues at HPI.
Thank you very much, Gaya, for those insights. Incredible what you have managed in a very short time. Yes, we have still time to take some questions. So I'd like to invite the audience again to pose their questions in the Q&A area or in the chat, whatever you like. For a starter, I would be interested how you said the crowdsourcing with the translation, but maybe you can share some more information on how did you go about the translation of the courses in more than 50 languages, and you said you have to be really quick. So yeah. Muted.
Sorry. So I think, as I said, if your vision is right, people understand you're doing something for a global good. So this is not profit making, right? People are really attuned to what you're doing. So we're a big bureaucracy, we're a big organization, and to do formal translations, it takes a long time. So we realized very quickly this is not going to work for us. So we have very innovative colleagues in our team who already identified partners who do this kind of work in emergencies. So for example, we started our journey with Translators Without Borders. Then there was a private company called In What Language who said, okay, we want to do social good, we donate translations to you. So lots of people, either they were on contract, but really very low contract because of the nature of the work, or private companies who usually would charge a lot would come and donate translations free because they believed in the mission that we were pursuing. And then as the material became available to countries, countries would say, our country offices or people in the ministry or NGOs would say, oh, we'd like to have this in our language, can we help you? And we would say, yes, please. And we translate it. And we asked our country officers to validate the translation, right? And we always put disclaimers, it's the English version that is the standard. But, this worked because our country officers helped us. And one of the most remarkable ones we did was somebody from the impaired hearing, the deaf community in India, which is an enormous country, came to us and said, well, you're translating, how about in sign language? And this amazing person volunteered, right? We didn't have to pay him. I think we gave him a gift later, but really he volunteered, and they did the COVID introduction in Indian Sign Language. And later our Director General got a letter saying 18 million community workers are using this with people with impaired hearing in India. And this wasn't when, we had this peak in India. This was way before. So we didn't have to get excited when the numbers started going up India. This was well before. Right? So I think if people understand that your mission is right, it's for a social good, and of course we have to be flexible and accept that, and we have to have quality control. I think if we have that, that's primarily how we went about the translations.
Thank you. Any more questions from the audience?
So there's one in this one, but maybe this is not for me, but it's still a good question. I think it was for the previous speaker. We need tools for the community that includes content discovery. and curation. And then open source. So if I may say something on that.
Yeah, sure.
Yeah, and it's really speaking to that point that knowledge is no longer in institutions. Yes, institutions have a very important role, but the knowledge production, codification, transfer in institutions take a long time. And what we've seen is bringing practitioners together, particularly, across the world. So our clinical guidelines for COVID management, how were they developed? They weren't developed by somebody, in WHO or in university. What we did is we convened, I think it was 300 or 400 clinical practitioners who were in a network around the world, got them to help bring crowdsourced knowledge, use scientific methodology that was appropriate for an emergency, and then codified that, got a guideline, and then turned that into a training. So these are some of the, things that we have to do. The same with Ebola. Much of knowledge on how to handle Ebola in the community in West Africa did not exist. It was created in the field in West Africa, in communities in Liberia, Sierra Leone, and Guinea. So, we're asking people to wash hands, but 40% of the world's population doesn't have access to water. Well, you're going to have to be innovative, right? So there's nothing that I'm going to be able to tell them. So this shift, this mind shift, that knowledge is created in many different places, and we have to find ways to find it, to validate it, to codify it, and to share it with others, of course, mentioning the limitations and the contextual nature of this.
And what I also be interested is, like, you had to learn really quickly during the pandemic now, yeah? What would you say are the more mid-term learnings, or what you take further in the longer term work?
I think I have a renewed passion for this equity, that things must be free, accessible in people's languages. I mean, we started off with this idea, but the pandemic really, drew a red line under it and said, no, you must pursue this. You must proactively remove barriers to learning, right? So I think in terms of an operation, we're doing very well. I think this is good, everybody's happy with us. So I think that commitment to equity and access is important as a guiding light for everything we do. And practically, I think we have to really move out and offer, on top of the self-paced learning, we have to go with the synchronous interactive learning, not for such large groups. Well, once people have done that, how can we do that at scale? And that's very difficult to do it at scale. I mean, we did this with a couple of 100 people, but it wasn't possible. And really the third area that I really am finding it challenging, and everybody's finding it challenging, but we should put it out there, is competency-based learning. So people can design learning based on competencies, but we still haven't found out how to assess those competencies remotely at scale and quickly, right? So, particularly the softer, what we call soft skills. How can you work in new teams? How can you work under pressure? It takes a lot of resources to observe people to say they have the competency, but how do we do that at scale during an emergency? Because we're having to identify people to take on new roles in emergencies. So those are the three things, the values, the really doing more interactive learning, and third is assessing competencies at scale during emergency. So those are my three big nuts to crack. I hope people here are clever enough to join me in answering that.
Thank you. And maybe one last question I have, which kind of cultural differences have you observed in online learning?
Well, I mean, even I hated online learning before the pandemic, let's be honest. I thought, oh, I'll produce it and give it to somebody, but even I had to do it. So I think, it has become normal. So this is a great cultural shift across humanity, right? Whether, we're doing this over Zoom, I would physically go to a conference, I wouldn't do anything like this. So we as humanity know how to use digital tools for communication and learning. Everybody, including very highly qualified people, have understood they have to keep learning, right? So this concept of lifelong learning is coming. So I think these are two big changes in culture. But if you're talking about people's culture, yes, that's very important. We have to contextualize learning into people's cultures, but that can't be done at global level. So what we are doing is we're working with intermediaries, civil society, faith-based organization, in giving them the skills to access global or national learning and to help them contextualize it in the culture and the context. So I think those three aspects could be really important to going forward.
So thank you very much again, Gaya. This was very, very interesting. Now I'd like to move on to our last keynote speaker. Thank you. Our last keynote speaker has seen the need for